Good afternoon, everyone. Thank you, Frederick, for the introduction. I will discuss the role of PET imaging in the disease modification era of Alzheimer's disease, and I'm really grateful and happy for the title of my presentation, as it means the title implies that we are in the disease modification era. So I'm happy to discuss this topic as we are presently now in this new era, after decades in which, together with many others, have discussed the role of PET ready for prime time, next frontier for PET imaging, future roadmap, and emerging role. And this is I even quoted this editorial, and this is me trying to discuss that PET imaging is not superfluous, controversial, and certainly not a luxury issue in nuclear medicine. So the true question is, are we ready for the disease modification era? And together with the other speakers, we have tried to discuss how to be prepared to this new era. We believe that we need to improve our awareness about the importance of early detection of Alzheimer's disease, about the relevance of amyloid and tau pathology, and thus of amyloid and tau PET imaging in this new scenario. And we also need to be aware of the use of PET imaging in Alzheimer's clinical trials, as we know that clinical trials always pave the path for the future use in the clinical settings. So I would like to discuss these three topics, focusing on the situation, how it was yesterday, today, and how it will be tomorrow. So yesterday was the era of trying to show impact without the treatment. But even in this very complex scenario, potential benefits of early diagnosis were already evident. This was true for patients and their families, their caregivers, as early diagnosis allows to adjust to the patient's changes in function, mood, and personality, and to the transition of families to a caregiver role. They need to receive explanation about the symptoms. They need to plan ahead. They need to be prepared to access to right services and support. And also, and I believe this is a point that will be very relevant also in the future, in the era of disease-modifying drugs. Patients need to learn how to modify exposure to common risk factors with the aim to delay the onset of dementia. On the other side, proving the impact for the healthcare system was more complex, although the general idea is to meet greater upfront cost than balanced by a subsequent savings due to a reduction in social and care needs and institutionalization. But we know that this is very complex without a treatment. Even in the present scenario, in absence of commercially available disease-modifying drugs in Europe, amyloid and tau PET already demonstrated their value in terms of increase in clinician confidence in their capability to change diagnosis, as well as in their capability to change the use of drugs. And these figures come from the IDEAS studies. Is not based on a new scenario with the availability of disease-modifying drugs, is based on the present scenario. So even today, in absence of disease-modifying drugs, an accurate diagnosis is able to change treatment, to change drugs that patients receive to support, for example, just think about to the differential diagnosis between Alzheimer's disease and frontotemporal dementia and the use of cholinergic drugs. And very recently, also, some studies were able to demonstrate that the availability of the information provided by amyloid PET was able to impact the rate of institutionalization. So even today, the impact is quite clear. However, I would lie to you if without showing another picture again from today. This is a survey promoted by the European Alzheimer Disease Consortium. The question that European clinicians received was about the frequency of use of the different biomarkers. As you can see, um, uh, despite FDG PET is not able to capture neuropathological hallmarks of Alzheimer's disease, the frequency of use is significantly higher with respect to the use of amyloid PET and obviously of tau PET, which is not clinically available at the moment in Europe. So this is a true scenario. This answer corresponds to frequent to constant use. However, if in the same survey we move to a different question, we move to a question about the relevance of the information provided by the different biomarkers to come to an etiological diagnosis of Alzheimer's disease, as you can see, the significance of amyloid PET is really close to CSF, which is considered the first biomarker at the moment in Europe, also because it's less expensive and provides information about AT and N with just one biomarker. So clearly the significance of amyloid PET is from in this figure considered higher, much higher with respect to FDG. So this is clearly due to the fact that the use of amyloid and tau PET in Europe is still heavily affected by availability, cost, and reimbursement issues, which are on turn clearly affected by the lack of disease-modifying drugs. So why amyloid and tau are relevant for Alzheimer's disease? Why amyloid and tau PET are relevant? Because they can provide information about the ATN framework, as previously mentioned by Frederick. We know that more than just one tracer is needed to capture AT and then through imaging. However, we know that we can obtain information about amyloid pathology with a specificity able to track only amyloid deposition with no significant binding to other neuropathological proteins deposition. Not in Europe, but in the US, a tau tracer able to capture Alzheimer-related tau pathology is at the moment available, and still with FTG and also with MRI, we can obtain information about neurodegeneration. So why amyloid and tau PET are so crucial for Alzheimer's disease? We know that at the moment, all the clinical trials that reached positive results, as well as other ongoing trials, are able to track amyloid pathology, and another target for clinical trials is tau pathology. So our tracers are able to provide information about this target. And for these reasons, I believe that amyloid and tau PET are not only crucial for Alzheimer's disease, but most of all, also for us as nuclear medicine community. As if I tell you that we have a tracer that is able to track a target, and that this target is also a target for a disease-modifying drugs, I think that this construct will remind you to another very relevant model in nuclear medicine, the theranostic model, which is at present applied in many scenarios in oncology, and which is very relevant for patients and for us as nuclear medicine community. So I would like to move to a question about the role of PET imaging in clinical trial at the moment. So which is the role of tau and PET imaging in clinical trials? So a first possibility, patient's inclusion eligibility, B, disease staging, C, response to treatment, and D, treatment discontinuation, or E, all the above. Actually, the correct answer was E, all the above. Really, amyloid and tau PET have been included in clinical trials for many different reasons. I would like to end my presentation by discussing the different roles of amyloid and tau PET in all the clinical trials that have reached positive results. As we know, this paved the path for potential future use. So in the aducanumab trials, really controversial results. I will not enter in the detail of the trials, but as you know, patients entered because they were amyloid positive. They were proven to be amyloid positive through amyloid PET. Lecanemab trial, again, the patient could enter thanks to the information about amyloid, the presence of brain amyloidosis. And finally, a more complex but very elegant scenario of donanemab, in which patients were recruited, as already mentioned by Frederick, through both amyloid and tau PET. Amyloid PET was necessary, but it was not reported in a binary visual way. It was reported with a semi-quantitative approach by means of centiloid scales that will be more deeply discussed by the next two speakers, Alex and Lyduine. I would say that more than 37 centiloids correspond to a clearly positive amyloid PET scan, even more than positive, I would say. And tau PET was used to define the entity, the staging of these patients, to demonstrate the capability of the new drugs to provide effect on patients in different staging of the disease. That's why, basically, at the moment, if we summarize, amyloid PET can be used for diagnosis eligibility, to prove target engagement, which was clearly proven in all trials with positive results. This was similar for tau PET, diagnosis, target engagement, but also staging. But there are 2 points about amyloid PET that I would like to further stress. Amyloid PET was clearly able to demonstrate imaging-based response to treatment. I don't need to further stress that the relevant effect which is needed is the effect on cognition, the clinical effect, but it was also associated with an effect to imaging. But a final, very interesting way in which amyloid PET was used was to propose a criterion to stop treatment. And this idea, the idea of treatment discontinuation, is really relevant for several reasons. First of all, amyloid PET was demonstrated to be able to predict effectiveness as baseline amyloid PET levels, as assessed by imaging, were able to demonstrate a direct association with the magnitude of amyloid reduction, and were also inversely associated with the probability of achieving complete amyloid clearance. On the other side, and this is the new idea, a cutoff of centiloids, 25 centiloids, which again is based on the literature, is a cutoff for positivity, was used to decide when to stop treatment. And in a small number of patients, this approach was also associated to lack of significant accumulation in 1 year, and a reduction below 11 centiloids, which again it's something that come to data-driven literature, again, is in a small number of patients, was able to was associated to lack of reaccumulation in the following 24 months. This approach is relevant because it's of great interest also for a different stakeholder, different from us, different from patients. I would say the payers and the political side of this kind of decision making for the use of treatment and imaging to candidate and stop treatment in the next future. So this is the future. To be prepared for this kind of future, we need to be ready to use amyloid and tau PET in the present scenario, and this topic will be discussed by the next two speakers. Thank you for your attention.
Dear Chairman, dear ladies and gentlemen, thank you very much for the invitation to this interesting symposium. I will now present on advances in Alzheimer's disease PET biomarkers. These are my conflicts of interest. Talking about biomarkers, we need to be aware that different factors are suggested to be involved in the generation of Alzheimer's disease. This is amyloid pathology constituted by extracellular aggregation of beta amyloid protein. This is intraneuronal aggregation of neurofibrillary tangles built up from tau protein, and both of these pathologies are suggested to result in neuronal injury constituted by synaptic dysfunction and neuronal loss. These categories of pathology are referred to as classification A, T, and N, and we are today in the fortunate situation that we do have imaging biomarkers available which allow us to capture all three categories as constituted by amyloid PET, by tau PET, and also by FDG PET, allowing the assessment of neuronal injury. FDG PET is to be considered the best established imaging biomarker for neurodegeneration, providing some kind of information in basically all kinds of neurodegenerative disorders. FDG PET is a measure of neuronal injury, and characteristic findings have been described for the different types of neurodegenerative disorders, as we can see on top of this slide here. However, One specific neuropathology may result in different patterns of neuronal injury, and also different neuropathologies may result in similar patterns of neuronal injury. So an etiological diagnosis is not always possible, but increasingly important with the advent of new causal therapies. So there's obviously a need for etiological imaging biomarkers. In this context, we have biomarkers available now, such as the amyloid imaging tools. There are 3 different amyloid imaging biomarkers currently approved by the FDA and the EMA, all of them also commercially available. By autopsy trials, it has been confirmed that these biomarkers have a high sensitivity and specificity for proving the presence of amyloid aggregates in the brain. This has a particularly high negative predictive value, meaning that if there are symptoms present but no amyloid is detected, the probability that this is Alzheimer's disease will be very low. On the right side of this slide, we can see typical findings in a healthy control subject without any distinct uptake in the cortex. In the bottom row, we see a typical finding in Alzheimer's disease with intensive uptake of the tracer in the cortex, reflecting amyloid plaque deposits. What about the value of amyloid imaging for early diagnosis or prediction of Alzheimer's disease? It has been demonstrated that about 20 to 30% of subjects above the age of 60 years show some amyloid aggregation in their brain even without any cognitive symptoms. However, from this finding, not easily a risk for conversion to Alzheimer's disease in the near future can be derived, as we can see on the left side of this slide. Amyloid positive healthy subjects have been shown here to show a conversion to mild cognitive impairment within 5 years in a percentage of about 20%, meaning that the rest of the amyloid positive healthy subjects in that group did not show decline during this period. It looks different for patients with onset of cognitive impairment, as we can see on the right side of the slide. Here demonstrated for patients with mild cognitive impairment, a relatively high proportion of these subjects showed a conversion to manifest dementia of the Alzheimer type within 5 years, reflected in a high sensitivity for prediction in these patients. Recently, more evidence has been collected on the value of amyloid PET imaging for early diagnosis. This refers to the so-called AMIPAT trial, the largest European randomized controlled multicenter prospective study on amyloid PET in clinical practice. In the first branch of this trial, patients were randomized to receive amyloid PET or not, and it has been demonstrated that in the subjects who did receive early amyloid PET in their diagnostic workup, a diagnosis with very high confidence was possible in 40% of cases, whereas this was only possible in 11% of cases of patients without early amyloid PET. Also, a change in diagnosis has been resulting from amyloid PET imaging in the first population. This study also included MCI subjects and even subjects with subjective cognitive decline, meaning they did not have any objectifiable cognitive impairments. The second branch of this trial included healthy control subjects who were stratified according to results in their amyloid PET scan. Here it has been demonstrated that the baseline amyloid burden was associated not only with cross-sectional cognitive performance, but also with decline in cognition and brain atrophy over time. Also, it has been shown that thresholds can be defined which are associated with functional decline over time. What about the value of amyloid PET imaging in differential diagnosis? Here we can divide between two categories of potential value. One is the detection of atypical Alzheimer's disease. And we see here three examples of atypical Alzheimer's disease: posterior cortical atrophy on the left, logopenic aphasia in the middle, and the frontal executive variant on the right, as reflected in their FDG PET scans with very different patterns of neurodegeneration. All three of these cases did have a positive amyloid PET scan, as we can see in the bottom row of this slide on the left side. So these patients showed different phenotypes, but the same pathology underlying their cognitive impairments. The second category of differential diagnostic value is the exclusion of pseudo-ID, meaning patients looking like Alzheimer's disease from their symptomatic appearance, but suffering from other causal neuropathologies. In this context, the so-called IDEAS trial is of great value. This was the largest trial so far performed using amyloid PET imaging, including more than 11,000 patients. This trial showed a change in diagnosis in 25% of cases which were suggested to suffer from Alzheimer's disease and were changed to non-Alzheimer's disease after their amyloid PET scan. That means that in these patients, the symptomatic appearance resembled Alzheimer's disease, but the biomarker test disclosed that they are suffering from another causal neuropathology. A change in management resulted also in more than 60% of cases here. So these patients had the same phenotype of symptomatic appearance, but different pathology, and amyloid imaging has been demonstrated to be of value here. What about the quantification of results? The typical approach in interpreting amyloid PET imaging results so far is based on visual assessment of amyloid positive or amyloid negative findings. However, the data can also be quantified, and for that purpose, the so-called centiloid scale has been introduced. This is a sort of standardized exchange rate of the SUV values into a scale ranging from 0 to 100, where 0 would be the mean value detected in a group of young healthy controls, and 100 would be the mean value detected in a group of manifest Alzheimer's disease patients. The elegance in this approach is that different amyloid PET tracer results can be translated basically into the centiloid values, and by that also compared with each other. And this also has been recently integrated in the package inserts of the amyloid PET tracers, where it says now that quantitative information can be used as an adjunct to visual interpretation. For absolute quantification of PET data, we usually would require dynamic PET data, but this is of course burdensome for patients. But again, also in the AMIPAT trial, it has been demonstrated that this can also be done by the so-called coffee break protocol, meaning that an early time window is acquired and combined with a late specific time window, and the patient can leave the scanner in the time in between. This has an additional advantage because the early time window also can be used as a substitute for FDG PET, as demonstrated on the right side of this slide, because the perfusion signal acquired in the early phase here resembles the FDG PET information quite obviously. So moving to tau PET, there have been several tracers now also introduced for tau PET imaging. A single tracer of them, the so-called Fluor Tau-CPR, is FDA approved since May 2020. So far, an EMA approval has not been achieved. Again, for approval, autopsy trials had to be performed, demonstrating high sensitivity and specificity values for this tracer with regard to the detection of tau pathology in the brain. On the right side of this slide, we see typical examples of a healthy control subject with no uptake in the cortex, whereas we see an Alzheimer's disease subject in the bottom row with distinct tracer uptake in the brain reflecting tau pathology. What's the value of tau PET for early diagnosis in prediction? Again, there have been some studies now performed demonstrating some value in predicting cognitive decline in cognitively healthy subjects, as demonstrated on the left top side of this slide. And also it has been demonstrated that there is a value for prediction of Alzheimer's disease in subjects with mild cognitive impairment, as demonstrated on the right side of this slide. Importantly, these findings all referred to populations who were amyloid positive. So a high predictive value was observed in cognitively healthy subjects who were at the same time amyloid positive, not only tau positive. And the same is correct for prediction in mild cognitive impairment. We will require prospective studies to study the value of tau PET for prediction in the future. What is the value of tau PET for differential diagnosis? Tau PET may have additional benefit here, as it not only demonstrates the presence of a pathology in the brain, but also the location of the ongoing neurodegeneration, as we can see in the top left corner of this slide here. We see patterns of tau aggregation here in typical Alzheimer's disease, but also in the frontal type, in posterior cortical atrophy with a distinct occipital uptake, and in the logopenic variant of progressive aphasia. These results are different from amyloid PET imaging, which would show relatively homogeneous distribution of amyloid pathology also in the atypical variants of Alzheimer's disease. In the left lower corner of this slide, we see tracer uptake in a patient with progressive supranuclear palsy. This is a so-called 4-repeat tauopathy, which is different from the tauopathy found in Alzheimer's disease. And there are studies ongoing recently with the next generation tau PET tracers who are suggested to have a value also with regard to detection of this kind of 4-repeat tauopathy. Again, the pattern of distribution is important here. Studies also demonstrated that amyloid positive and amyloid negative subjects can be differentiated on the basis of their tau distribution pattern, as demonstrated here in the middle of this slide. This has been a deep learning algorithm in which it has been demonstrated that nicely amyloid positive, amyloid negative, and tau negative subjects could be differentiated on the basis of their tau PET findings alone. Last not least, again, as for amyloid imaging, the early phase of tau PET imaging can be used as a substitute for FDG PET. So taking it all together, it appears that tau PET may in the future serve as an universal biomarker tool, providing some information on A, T, and N status of the patient in a single scan. What about visual and quantitative assessment of tau tracers? Again, the visual read of tau PET scans would result in a tau positive or tau negative results. Importantly, a positive tau scan would support the presence of widely distributed tau neuropathology. Scans with uptake in the mesial temporal lobes or minor uptake in frontal cortical or anterior temporal cortical regions would not be considered as tau positive in the sense of widely distributed Alzheimer typical tau neuropathology. Also recently, semi-quantitative assessments have been introduced, as we can see on the right side of this slide here, with the so-called Centaur scale. This would be the analog to the centiloid scale presented for amyloid imaging just before. and presumably could again result in a more standardized quantitative readout, also allowing comparison of different tau PET tracers. There have been appropriate use criteria published before, by that time referring only to amyloid PET imaging. The indications for amyloid imaging here were listed as progressive, persistent, unexplained mild cognitive impairment as one. Second, possible Alzheimer's disease. The emphasis here is on possible, which does not include probable Alzheimer's disease. And the third indication would be patients with early onset of cognitive impairment, meaning below the age of 65 years. It was considered inappropriate to perform amyloid imaging in patients with probable Alzheimer's disease with typical age of onset to determine dementia severity instead of genotyping in asymptomatic individuals or for non-medical usage. As these criteria have no longer been considered to be fully appropriate with regard to the current state of knowledge, an expert work group has been assembled trying to find new appropriate use criteria, now referring to amyloid and tau PET. And this is currently still work in progress. The additional indications here for amyloid PET and also for tau PET imaging would be the inclusion of patients with onset of the disease at 65 years of age or older, as it has been demonstrated that also patients with probable Alzheimer's disease with a regular onset in a relevant proportion would not show amyloid accumulation in their brains. Also, it has been included as an indication to inform on the prognosis of patients presenting with mild cognitive impairment due to clinically suspected Alzheimer's disease pathology. For amyloid PET imaging only, indications have been included now for subjects with equivocal or inconclusive results on recent CSF biomarkers, and of course to determine eligibility for treatment with the new approved amyloid targeting therapies. Additional indications for tau PET only have been added to inform on the prognosis of patients with dementia due to clinically suspected AD pathology, as tau aggregation in these patients still correlates well with the progression of disease. An important question is the value of the PET biomarkers as compared to the CSF and recently also blood biomarkers. In general, one can postulate that the fluid biomarkers rather reflect an indirect measure of the activity of the pathological process ongoing in the brain, whereas the imaging biomarkers reflect the extent or status of the neuropathological damage in the brain directly. But importantly, also both of these biomarkers do not correlate linearly, as we can see on the left side of this slide here. What is quite obvious is that the levels of A-beta in the CSF indicating amyloid aggregation pathology decline quite early, whereas the PET levels still appear normal, and only if levels go below a certain level, the PET biomarker abnormalities appear to increase. And this may reflect a temporal offset of the value of the two biomarkers, indicating that the early onset and progress of soluble or dynamic aggregation pathology in the brain cannot yet be judged by the PET biomarkers, as we can see on the left side of the diagram on the right half of this slide, whereas the onset and the extent of aggregated pathology burden later on can be judged by PET, but not by the fluid biomarkers, which have reached a plateau by then. With regard to this information, we may want to come up with a new biomarker classification concept differentiating between the soluble biomarkers and the aggregated biomarkers of amyloid and tau pathology, as summarized on this slide here. With this, I want to move on to a case example. This refers to a 72-year-old man who had difficulties in reading, orientation problems, and issues with driving his car and using tools. The neuropsychological tests demonstrated visual impairment, but only minor impairment in memory. If we look at the imaging findings, we see the FDG PET here on top and the tau PET evaluation in the bottom row. What's quite obvious is that on the FDG PET scan, hypometabolic areas appear in the bilateral parietal and also occipital cortical regions, which is also nicely reflected on the surface projections. The tau PET scan looks like a mirrored FDG PET image where we can see distinct accumulation of the tracer again in posterior parietal and occipital regions of the brain bilaterally in rather the same distribution as demonstrated for the hypometabolism on the FDG PET. So the question here would now be, what is the correct answer? 1, the patient probably has a positive amyloid scan. 2, the patient needs to see an ophthalmologist. 3, the patient probably has an abnormal dopamine transporter status. Or 4, the patient suffers from an encephalitis. The correct answer here would be number 1, the patient probably has a positive amyloid scan. And this is explained as follows. The diagnosis here is posterior cortical atrophy. And as mentioned before, posterior cortical atrophy is an atypical variant of Alzheimer's disease. The patients often show non-memory complaints, particularly a decline in vision and literacy skills, and they frequently have futile visits to ophthalmologists in their patient history. The amyloid PET is positive because this is an atypical form of Alzheimer's disease. FDG PET in these cases often shows distinct posterior parietal and occipital hypometabolism, often still sparing other regions of the brain. And the tau PET, as we can see, shows a similar pattern of increased tracer retention in the affected areas, demonstrating that the neurodegeneration occurs in exactly these regions which are tau positive in the brain. Amyloid PET, as demonstrated in the right lower corner of this slide, is positive, but quite generally all across the brain, not only limited to the neurodegeneration affected regions of the brain here. With this, I want to thank you very much for your attention.
Hello, everyone. I'm Lyduine Collij. I'm a postdoc researcher at Lund University, Sweden, and also affiliated with Amsterdam University Medical Center in the Netherlands. And I would like to present on amyloid PET tracer, which, who, and how, and with a particular focus on the how, because I do think there are some methods that we now have quite established, which we might not be utilizing optimally yet in our clinical routine, but also some new methods out there that could also maybe even add to our clinical use of amyloid PET tracers. But these are my disclosures. And I first want to start with a question of the lay of the land. So for you, do you use amyloid PET in the clinical workup? Never, sometimes, often, or always included part of your standard workup? So in the live presentation, we saw that we often had, well, often and sometimes filled in. So amyloid PET is more and more used in the clinical routine, which is not maybe on a standard workup basis yet. But things might change, of course, in the near future, considering all the developments in the anti-amyloid trials that Frederick already alluded to. So to start with the first question, what are the amyloid PET tracers that we have available and which one should you use? The three commonly used F18 tracers are flutamate-mol, florbetaben, and florbetapir, which you can see here. They all have their own visual guidelines and slight differences in how we assess them in terms of color scale or signs that you look at. But in essence, they're all FDA and EMA approved for clinical use because they bind to what we're interested in, which is amyloid beta plaques. And despite having some slight different kinetics, they all have shown very high agreement with postmortem data for this purpose. And also, importantly, they've also shown high comparison to the gold standards, which is in the first developed amyloid PET tracer called Pittsburgh compound B, or PIP. If you focus on the diagnostic performance on the right side of the curve, there's a high percentage agreement between the F18 tracers and the PIP tracers. So how do we use these different radio tracers in our routine clinical use? And a common actually reference that is what we call visual assessment of the scans. So visual assessment has a few important steps to take into account where we're assessing these scans. And the first one is proper orientation of the image. So our proper orientation of the image is key because otherwise you might be looking into white matter, while of course we're interested in signal in the gray matter. Because all F18 tracers, and even also PIP, but particularly the F18 tracers to a certain extent, have off-target binding or noise signal in the white matter. And that's something you want to discard. So a few things that we do is that we orient the scan according to the anterior-posterior plane, as you can see on the top, where there's a straight line between the anterior corpus callosum and the posterior corpus callosum. The midline should be completely straight, and you should align the temporal lobes. When this orientation is done, you can scale your image to know what is the off-target or reference signal that you're looking at. So in case of flutamate-mol, you scale to the pons, where we always see high uptake, as you can see in the top negative scan indicated here. So you scale to 90% intensity of the pons, while for florbetaben and florbetapir, you scale to the deep white matter and 90% of that signal. Then you assess the individual regions, which are the frontal, lateral temporal, precuneus, lateral parietal, and striatum region in case of flutamate-mol. So the striatum can only be, it's only part of the visual guidelines in flutamate-mol PET scans, while for the other two, it's the first few. And the classification of the image is actually relatively straightforward. It's considered positive when one of these regions is abnormal unilaterally. So if you just have in one hemisphere, one region abnormal, that is considered to be a positive scan. So a question to the audience, which scan do you think shows abnormal uptake or is positive? Scan 1, scan 2, both scans are positive, or neither scan is positive? What do you think? And the correct answer actually is that both scans are positive. In scan 1, you can see some early uptake in the frontal regions, where you can see both on the first image here in the axial view and here orbital frontal view, while scan 2 is more advanced positive. So what I want to indicate with these two examples is that both these scans will be visually assessed as positive, but you could appreciate the huge range or differences between them in the extent of pathology. And this is information we're not using yet into the clinical routine, but might actually be very useful. So one of the few things that has been updated recently was already also shown by my colleague Alex, was the updated appropriate use criteria, which has been presented this year at the Alzheimer Association Imaging Consortium in this summer in 2023. And this proposal has updated the use for which patients or which subjects it's considered to be useful to have amyloid PET or tau PET during the clinical routine. The one thing I want to focus on is that they mention that we can inform prognosis of patients presented with mild cognitive impairment due to clinically suspected AD pathology. And you can see that actually, while before amyloid PET was purely used as a diagnostic tool, it's now being considered to actually could be useful as a prognostic tool as well. And this is where the extent of pathology might come into play, which I mentioned in the previous slide. So what is the evidence so far that we have for amyloid PET-based risk stratification? So in the years of staging models that we had in the past few years, people have attempted to use the extent of pathology, the regional information that we have in amyloid PET scans, to stage subjects according to the extent of burden. This is one of the first models that came out from Bernard Hansu and colleagues, where they simply stage someone where they had cortical uptake, striatal uptake, or both. And what you can appreciate, particularly in those with mild cognitive impairment, is there's a sort of stepwise effect of amyloid burden on risk of cognitive decline. And subsequently, other staging models came out that tried to describe the cortical distribution a bit more, see if there's more information to be gained. And for example, a model by myself as well, what you can see here, we showed that if you stage according to cortical amyloid burden in the ADNI cohort, which are also mainly MCI subjects, you could already appreciate also the stepwise effect of the extent of pathology and the risk of cognitive decline. So that brings us to how could we further improve our use of this modality in our clinical routine. Quantification has been recently suggested that could support visual assessment and maybe also a risk stratification. So beyond, especially in those cases where visual assessment might be more tricky. So these are two examples of large studies that have recently been published, one for flutamide and one for forbetaben, where the visual assessment has been compared to quantification measures, either across a few large cohorts on the left or across different softwares on the right. And what we can appreciate is that the agreement between visual assessment and quantification is very high in a more clinically advanced cohort, which brought a lot of several studies to conclude that quantification could be useful in the support of visual assessment. But as you know, we do not live in a perfect world. This is work from in Amsterdam with the ABI cohort, which not only captures the advanced clinical population, but also those with subjective cognitive decline. So basically, we have the full range of patients that we could see in a memory clinic. And here you can see the visual assessment color-coded against a quantification measure called Centiloid. And you can see there's not a perfect agreement between the two measures, though the agreement was definitely very high. Similar things have been shown for flutamide or by our colleagues in the States with the IDEA study for florbetapir. One thing that all these three studies have in common is that they've been utilizing the Centiloid method, as it has been shown to be a measure that reflects the extent of pathology. The Centiloid method has been introduced by Klonk and colleagues in 2015, and what basically it attempts is that it scales a quantification measure to a common scale. So while an SUVR of 1.4 in one site with one particular tracer on a scanner does not mean the same as 1.4 in a different site with a different trace in a different scanner, a Centiloid of 50 means exactly the same between different sites, scanners, and traces, or even reference regions, as shown in this plot. Within the AMIPAD consortium, we've been stress testing the Centiloid concept to see how robust it actually is, and if it indeed measures the extent of pathology as well as it says it does. So we compared 32 pipelines, think of MNI space, native space, different reference regions, different reconstruction settings, and the overall results actually, the measure is very robust. The paper is currently under review, but if you're interested, it's available by bioRxiv. You can see the reference here. And then recently also a nice review came out that showed that when Centiloid was compared to different reference populations, different reference data sets, that actually varies cutoffs for specific disease stages very robustly identified across these different approaches. So when we compare, for example, to neuropathology, we saw that a value of 10 or 12 and below indicates the absence of amyloid beta plaques, while the value of 30 or above indicates a high confidence of having a beta pathology in the brain, while 50 centiloid, for example, was related to a clinical pathological diagnosis. So a lot of studies are now ongoing to understand what is happening in a more so-called gray zone, so between 12 and 30. When can we say there's reliable amyloid pathology, or there's an increased risk for someone to get amyloid pathology? But I think it's quite striking that a number of these studies have investigated this method from a different angle and find very similar cutoffs. So because of these hypotheses and ideas of quantification supported visual assessment, we actually set out to be the first prospective study to see what actually happened to a visual assessment of difficult cases when we give the readers quantitative results. So what we did, we selected cases from the AMIPAD Diagnostic and Patient Management Study, which is the DPMS, which includes over 800 subjects from subjective cognitive decline until dementia, so the full clinical range, across Europe. And we selected a subsample of 85 amyloid PET scans for which the local reader had a low confidence, so that meant a 3 or below on the 5-point Likert scale, or the visual assessment by the local reader was discordant with the amyloid status based on centiloid, and we used a cutoff of 21. In addition, we added some purported negative and positive cases across the two traces. So we have flutamate and forbetabend in this study. And we ended up with 101 cases to balance the data set a bit. Then 5 trained and certified readers assessed all the scans before and subsequently again after disclosure of the quantitative results. And the quantification was provided by AmiPipe, which is a modified version of Cortex ID, which is a PET-only pipeline that provides the centiloid and regional Z scores. And it's modified because it does not only include a reference data set for flutamate, but now also for forbetabend. Our main result in this work was that global centiloid and regional Z score quantification was considered to be supportive of visual read in a substantial number of percentage of cases. And after disclosure of the quantitative results, we saw an improvement of the concordance between the readers from a kappa of 0.65 to 0.74. And remember, this is like the most challenging collection of scans that we can have in a clinical population. So achieving a kappa of 0.74 was quite impressive. I was happily surprised. And an increase of reader confidence from a score of 4 to 4.3. And all this together becomes even more important. Think of the recent developments in anti-amyloid trials, where we see that centiloid is not only used now as an inclusion measure, but also as an outcome measure of the effect of the anti-amyloid drug. And consider it's an inclusion measure, and with the hope that these drugs will become available in the upcoming time, also in Europe, it might be extremely key to have our readers and users of amyloid PET familiarize themselves with a measure like centiloid, that by the time it becomes mandatory, we already know how to work with it. So then a question again to you, to the audience, and I hope I could illustrate a bit to you when quantification could be of use. With this particular case, would you request quantitative results for this amyloid PET scan? Yes, and as a standalone measure? Yes, but in conjunction with visual read? No, visual read is sufficient. In the live presentation, we saw a bit of a mix between answer B and C. And that is sort of what I wanted to indicate, that this is a more advanced positive case where quantification might not be considered to be needed, especially when you have a trained reader. What about this one? Would you like to request quantitative results for this amyloid PET scan? Yes, and as a standalone measure? Yes, but in conjunction with visual read? No, visual read is sufficient. And with this question during the live presentation, we saw that mainly answer B was provided. This is indeed an example of a more early amyloid positive case. So you just see a little bit of orbital frontal cortex, and definitely having a quantitative confirmation of this suspicion would be very nice. Two scans, you can see the difference between the two. And the final point I would like to make is that now I've shown you how quantification could be helpful in terms of supporting visual assessment. It gives us an indication of the extent of pathology, but it's still something we're not using yet. This is work, again, from the Amsterdam group, where we showed that based on clinical stage, so SCD, MCI, dementia, you would expect a certain extent or burden of amyloid pathology, and you can appreciate a stepwise increase that we're observing here for the AD cases in the red colors. This is definitely more work needs to be done here, but this is the first indication. Maybe the extent of pathology can also provide us an indication if we're looking at a primary etiology or co-pathology. For example, if you get a dementia patient who has amyloid positivity, but only in the precuneus with, let's say, a centiloid of only 25, are you looking at a dementia due to AD, or are you looking at a co-pathology that also is there present? And you should maybe look further into the primary driver of the cognitive impairment of this particular patient. As I said, this requires further studies, but I think that will be a very relevant question to answer. And finally, what about heterogeneity? There's many staging models, and I've shown some pictures where you see quite a stable trajectory of which region seems to become abnormal first. But I myself am a trained reader. I've seen many amyloid PET scans, and I observed often, especially in the cognitively unimpaired subjects, that we have people had early uptake in the frontal regions, in the precuneal regions, and a subset has occipital uptake, which is not even included in the visual read guidelines at the moment, and most quantification approaches as well. And in this work, we actually applied a data-driven model to over 3,000 amyloid PET scans and found evidence for 3 subtypes of spatial temporal trajectories. And with first indications showing some demographic differences between these and some genetic risk. And it is actually a focus of my current work to understand these subtypes and their clinical utility. The take-home messages of this presentation are: we have several FDA and EMA-approved radiotracers that are available to reliably measure amyloid beta pathology in vivo. Amyloid PET can improve risk stratification of cognitive decline beyond binary classifications. Visual assessment of amyloid PET images could be supported by quantification, and this is particularly the case in challenging cases or in centers where you have less experienced readers. And as I mentioned, quantification might become key in upcoming years, considering the recent developments in anti-amyloid therapies. And we need to familiarize ourselves with these approaches before they become mandatory. And with that, I would like to thank you for listening. I'd like to thank the organization for inviting us to present this, and of course, my Biofinder group and the Amsterdam UMC. Thank you very much.